Hello and welcome to today's presentation on ECG signs of ST elevation myocardial infarction. If you recall, in our previous tutorials, we said STEMI. On STEMI, there is a complete occlusion of the coronary artery. And so, acquiring an ECG within the first 10 minutes when the patient presents at the emergency room should be the first step in recognition as well as treatment of STEMI. Now, before we look at the ECG signs, I want us to also know that we may classify STEMI according to the location of the infarct. And so we may have inferior STEMI, anterior STEMI, lateral as well as anterolateral STEMI, and also inferiolateral STEMI. What do I mean by all these? When we say inferior STEMI, then we mean the area which is supplied by the right coronary artery as well as the right marginal artery. So areas involving the right ventricle, as you can see in green over here. Now, it may also have continuation with the PDA, that's the posterior descending artery, and so all the areas supplied by the PDA may also be infarcted, especially when there is an occlusion in the main right coronary artery. Then the right marginal artery will be also occluded, or the area supplied by the right marginal artery may be infarcted, as well as the PDA. Now, when we say anterior wall STEMI, then we mean the area which is supplied by the LAD, which is the left anterior descending artery. That is this area. And when we say the lateral STEMI, we are referring to the area supplied by the circumflex artery. Now, we may also have anterolateral STEMI. In this case, that means that all the areas supplied by both the LAD as well as the circumflex artery may be infarcted, and so there may be an occlusion of a proximal portion of the left coronary artery. And as we discussed, we learned that the left coronary artery rises from the aorta and travels about 2 to 3 centimeters, then branch into the LAD as well as the circumflex artery. And so if there is any occlusion in the proximal part of the left coronary artery, as I've indicated over here, that means all the areas downstream the left coronary artery is going to be infarcted, and this will usually be a massive infarction with a very poor prognosis. We may also have septal wall, where we are going to have the area supplied by part of the LAD over here. Then also inferiolateral. When you say inferiolateral, we are referring to the areas supplied by both the PDA as well as the area supplied by the circumflex artery, because we saw that the right coronary artery branch also to form the PDA posteriorly, and the circumflex artery also supplies posteriorly. Now, in this slide, we are going to look at how a normal ECG, ST segment looks like. In this diagram on the right here, you can see the ST segment on the isoelectric line over here. So this is a normal ST segment. Now, in a pathological ST segment, as in ST segment elevation, this is what we see. This is the isoelectric line or the baseline, and you can see where the J point is. You can see that it is elevated or it is raised from the isoelectric line over here. So this is what we call ST segment elevation. This is another form of ST segment elevation, as the arrow is pointing. This is a isoelectric line, and obviously you can see that the J point is somewhere over here, and this is going to be RT. So in this we are going to find an ST segment elevation. So when you pick the ECG, what must you look for? Now, if we are looking for ST segment elevation and you find these pathologies in standard lead 1, you find this pathology in standard what do you call it, AVL, as well as precordial lead V5 and V6, then we are talking about, a lateral wall STEMI. If you find it in standard lead 2, standard lead 3, as well as AVF, then we are talking about an inferior ST segment elevation. If you find it in V1 and V2, then we are talking about the septal or anteroceptor ST segment elevation. Then if you find it in V3 and V4, we are talking about anterior STEMI. Now, quickly, let's look at a case scenario and use it to learn our ECG. Now, a 65-year-old man, is brought to the emergency room within 3 hours of chest pain onset. And so what must we do? Quickly, we must take an ECG within 10 minutes. And this ECG is showing us inferior ST segment elevation. So after assessing the patient, we gave 162 milligram of aspirin per hour. Then we started our antiplatelet therapy as well as anticoagulation therapy. And this anticoagulation therapy should always be given according to the PCI hospital standard. Why? Because some centers suggest that if stenting can be done within 1 to 2 hours of the attack, then thrombolytics should be delayed, since during stenting it may cause or it may increase bleeding in the operating field. But if the patient delays in coming, as in our case now, or the patient finds it difficult or is difficult reaching the PCI center on time, then thrombolytics should be initiated whilst we are transporting this patient to the center. Now, we are having inferior STEMI. What must we know about inferior STEMI? Some clinical facts. Inferior STEMI account for about 40% of myocardial infarctions. And all patients with inferior STEMI will have a concomitant right ventricular infarction. Why are they going to have right ventricular infarction? Because we saw in the previous slide that in inferior wall, we have the right coronary artery supplying that part of the right ventricle as well as the right marginal artery. And so if there is any occlusion over there, then we are going to have right ventricular infarction. And these patients may develop severe hypotension when we give them nitrate, and this usually may worsen our prognosis. And so we advise that nitrate should not be given, or it should be delayed in patients who are having a systolic blood pressure less than 90 millimeters per mercury. And also another thing that we need to know is that most patients with inferior STEMI will develop significant bradycardia. And this bradycardia is usually due to a second or a third degree AV block. And this usually may increase the mortality while the patient is in the hospital. Inferior STEMI may also be associated with posterior infarction. And if there is a posterior infarction, the prognosis is very bad. Why can there be a posterior infarction? As we saw, the right coronary artery gives a branch to form the posterior descending coronary artery, and so it supplies the posterior part of the heart. And so if there is any occlusion over there, there may be an infarction of that side of the heart. So how do we recognize an inferior STEMI? It's simple. Now there's going to be an ST elevation in the inferior leads. And which inferior leads did we see? Standard lead 2, lead 3, as well as AVF. We may also find the development of pathological kill in standard lead 2, lead 3, as well as AVF. Now, the moment you see this, you must quickly look at your AVL. When you look at AVL, there will be a reciprocal depression in AVL, and sometimes also in standard lead 1. So the moment you see your ST segment elevation in your inferior leads, quickly go to the AVL, and you may find a reciprocal depression instead of ST elevation. Is rather going to be an ST segment depression in AVL as well as in standard lead 1. Also, we may see in some cases that the ST elevation may in standard lead 3 may be more than ST elevation in standard lead 2, and this gives us a clear indication that the right coronary artery is involved. Sometimes, or even most of the time, there is also reciprocal ST depression in standard lead 1. I've said that already. And also we have ST elevation in V1 as well as V4. Now let's quickly go through this ECG. What do we see on this ECG? On this ECG, we find, as our case suggests, we are looking at inferior STEMI. So where do we look at? We are looking at standard lead 2, lead 3, and AVF. So as we can see, look at standard lead 2, we can find an ST elevation in standard lead 2. We can also find it in standard lead 3. Then also in AVF, we are going to find ST elevation over here. Then quickly, we must go to standard, we must go to AVL. And in AVL, rightly so, we are seeing a reciprocal ST segment depression in AVL as well as in standard lead 1. So this is typical for inferior STEMI. Now we can also see that the ST elevation in standard lead 3 is more than the ST elevation in standard lead 2, and so this may suggest a right coronary artery occlusion. Yeah, and there is also an early what do you call it, Q wave formation or pathological Q in standard lead 3. So if you look at standard lead 3, we can find pathological Q over here. This is what we call pathological Q. Now let's quickly look at another ECG. In our second ECG, what do we see? Still looking at inferior leads. You can pause this and try this by yourself. Then later you continue to see whether you are right or wrong. Now, since you are looking at inferior STEMI, where do we look at? Standard lead 2, lead 3, as well as AVF. And what do we see? In standard lead 2, we are going to find ST segment elevation in 2, as well as standard lead 3. Then we go to AVF and we are going to find ST elevation as well. Now, quickly, let's look at AVL, and we are going to find a reciprocal change or reciprocal ST depression in AVL, as you can see here. As I said, sometimes you may also find it in standard lead 1. So this is typical inferior STEMI. Now we may also find a pathological Q in standard lead 3 as well as AVF. So we are going to find a pathological Q, and also we are going to over here, then also we are going to find it over here, as you can see over here. Now in this ECG, we find that the ST elevation in standard lead 2 is almost the same as the ST elevation in standard lead 3, and there is an absence, as I indicated, there is an absence of reciprocal change in standard lead 1. You understand? And so this typically points us to a circumflex artery occlusion. So in this case, we are going to have the occlusion in the circumflex artery. So that is it. Now let's quickly look at another ECG. In our third ECG, what do we find? Still, you can pause it and check if you get it. It's an inferior STEMI. So where are we looking at? Standard lead 2, lead 3, and AVF. So in standard lead 2, what do we see over here? We are going to find ST elevation over here in standard lead 3, ST elevation. Then in AVF, we are also going to find ST elevation. Then quickly, we must go and look at AVL, whether there is a reciprocal ST depression. Of course, there is. So here is it. ST segment depression in AVL, then also ST segment depression in standard lead 1. What else can we see? Is there something we can see? Yes, we can see that the ST segment elevation in standard lead 3 is more than the ST segment elevation in standard lead 2. So where does the occlusion occur? As we learned, this occlusion may be occurring in the right coronary artery. And so in this patient, we are going to find infarction in the right ventricle. Now, quickly, thank you very much. I think this is what I have for you. I thought I had extra ones for you, but this is what I have for you. So thank you very much for your attention.